Hi everyone, I'm Dr. Shweta Goswami, Medical Director, Ziva Fertility. We're based out of Noida and Delhi NCR. In continuation of one of my videos where I spoke about embryo selection, whether we should do a day 3 or a day 5 transfer, there is always also this debate of whether we should be doing a PGT-A or what's called PGS or genetic screening of embryos. So again, I'd like to repeat here that one size does not fit all. Not everybody needs a PGS. At the same time, PGT-A or PGS, they're used interchangeably, is extremely important for some of the patients. So let's understand what is PGT-A in short and why does anybody need it. So as I said, I discussed in my previous video, in IVF, ultimately once we've extracted the eggs, the important thing that we're doing in the lab is embryo selection. We're saying you may have 10, 15 eggs to start with, but which are the embryos that make sense? Which of them could be chromosomally healthy? Which ones of them are healthy enough to give us a healthy offspring or a baby? And so therefore the first basic thing that's done in the lab is retrieving the eggs, fertilizing them, and then culturing them for 3 or preferably 5 days in the lab, which is called blastocyst culturing. Now, once you culture, say, about 12-15 embryos in the lab, you get down to about 4 or 5, which nature itself, by microscopic examination, we can make out that nature helps us differentiate non-invasively that these embryos seem to be healthy and the others don't. And in this science, we say there are negative predictive values very high, which means if an embryo does not look very healthy, it's grade C or grade D, you could actually just make out under the microscope that they're probably chromosomally abnormal and they should not be transferred and probably be discarded. On the other hand, the positive predictive value of a healthy embryo is just about 40%, which again, in simple terms means, why do we transfer 2 embryos at IVF usually? Why don't we transfer 1? Because we say at least one of them will implant because probably only one of them is healthy. If you transferred only 1 embryo, which is non-genetically screened or the PGS done, then you must stand about a 40% chance, which at IVF is very less. If you transfer 2, then you tend to get about a 65 to 75% success rate. But there also we need to note that 80% of such pregnancies are usually singleton pregnancies and only 20% leads to twins, which means we're transferring 2 embryos, but mostly only 1 is implanting. Now, in case we want to know further in the lab that, why should we be getting into twin pregnancies? There are a lot of couples who just don't want twins. There are some who cannot medically, have twins. Then the concept of PGT-A or genetic screening of embryos comes up. It's basically like we've cultured from day 3 to day 5 and 50% filtering happens and nature tells us, okay, these embryos make sense. It's a further filtering process. We want to further filter out that out of 5 embryos that may be grade A, excellent looking blastocysts, what we call a 4AA or a 5AA embryo, or we call it a XB of AA grade, an expanded blast of AA grade in the lab. However, only 40% of them will be chromosomally normal. So actually testing it further to realize that which of them are okay is the test in simple terms known as PGT-A or a chromosomal screening of embryos, right? Now, there are 4-5 set of patients where it would be very important. The first one, as I mentioned, if a couple comes in, and we get those requests a lot nowadays, and they say, we do not want twin pregnancy. The very reason I don't want to do an IVF is I'm scared we'll end up getting a twin pregnancy. So we say, no, there's no need to transfer 2 embryos. You could actually do a PGT-A. If out of those 5 embryos, you get to know again that there are 2 healthy embryos, you could transfer just 1 embryo and get a single pregnancy, and also at a success rate of 65 to 75%, which is comparable to when you transfer 2 embryos. It's like you either blindly transfer 2 blastocysts or you transfer 1 PGT embryo. What we need to be realistic and understand is that it's still a 70% chance. Just getting a euploid embryo, the result does not mean you'll 100% get a pregnancy. The reason for that again is science is still imperfect. We probably don't know everything yet. There is a basic screening we do, but there is so much we still don't know. So nature and God probably decide which of these embryos is still healthy and they will implant. And therefore the success rate tends to be at about a 70% with a single embryo. So, but therefore one set of patients who would want to go for PGT-A are the ones who cannot medically or who on a personal front do not want a twin pregnancy, especially if somebody already has a child and they just want to complete their family with a second child. Again, PGT-A makes perfect sense for them. The second indication where PGT-A would be recommended is somebody who has failed implantation, which means you've done an IVF procedure, everything looked good, so you had very good healthy looking embryos on either the day 3 or the day 5 stage. The endometrial lining was good, which means it's an unexplained implantation failure. Again, according to science, 80% of such implantation failures are still attributed to embryo quality, meaning thereby you may have an excellent looking A-grade blastocyst, but it still does not result in a pregnancy because it's still chromosomally aneuploid. In such patients, it's very important to do a PGT-A because just looking at the embryos under the microscope and declaring them to be good quality may not be good enough. So we need to screen them further. A lot of times you do get, very surprising results. You may get that all embryos, even though they're looking very healthy, are aneuploid or chromosomally abnormal. So it does make sense for somebody who has failed implantation procedures in the past.
Continued in part 2.